it's sealed. It has, everything it needs to be fully compliant with all regulatory bodies, as well as a dispensing software that allows you to dispense the medication to the patient. So our big proposal for today and for you guys to consider is that in most states, if you're able to prescribe it, you're able to dispense it. We would like to see the same thing in New Jersey because it's great for the patients and it's great for the doctors. There's no more calls with the pharmacy about lost scripts. There's no more wondering if your patient took the medication. You're able to take that 60% adherence number to close to 100% because you're physically handing the patient a bottle of medication as they leave your office. So just on-site dispensing versus the status quo, this is not going after pharmacies or pharmacists by any stretch of the imagination. This is addressing a very real problem, which is there are a number of barriers to patients getting their medication from the way pharmacies are currently set up. There's not enough access. They're closing. They're continuing to close stores, and the industry is predicting more of those will happen. And this gives you the ability to directly impact your patients by providing them lower cost medications right at the point of care. It takes the complexity, it takes the confusion out of healthcare because you are giving them exactly what you as their doctor deems appropriate right there on site. I think one of the most shocking numbers is only about 60% of patient or prescriptions sent to pharmacies are picked up in the first place. So that's 40% of prescriptions where the patient is literally not following the doctor's orders. This puts that power back into your hands as the provider. And then ease of access is a huge thing. It's very, very popular with patients. We recently brought this program into a large group in Florida, and we saw dramatic increases very rapidly in net provider score, all driven by patient satisfaction. So this is not, like we said before, this is not eliminating pharmacy. This is not adding any scope creep. The simple proposition is anyone who can prescribe a medication should be able to dispense prepackaged medications. There's no advocacy that doctors would turn into pill counters or pseudo pharmacists. It's a very simple solution, at least with us, where you're able to quickly utilize your staff to get medications into patients' hands, and it improves access through the physician. It makes that patient-provider relationship much more close. It allows you to have better engagement, and better adherence allows you to get that access from your patients. This is simply about reducing barriers. There's a number of ways that we can work with and without the PBM, but in the best case for the patient and provider, this provides a way to go around some of the barriers like prior auth, which we heard mentioned at the top of the call, that really get in the way of you guys being able to efficiently practice medicine. So some of the benefits in clinic dispensing, and I've covered on a lot of these before, but it's improved outcomes through improved adherence. There's no more transportation barriers, improved patient satisfactions, and then an overall decrease in cost per scripts. But you can also add in there's reduced hospitalization because the patients are following the doctor's orders. They're taking the medications that they need. There's overall improvement in patients coming back for their visits because there's an incentive for them to come and get their refills. And it increases the clinic's productivity, which I think is very important. So it reduces your amount of time on the phone with retail pharmacies. It reduces your need to re-script a medication. It reduces prior auth turnaround times, dissatisfied patients calling you, confusion as to what medications they got. There's just a lot of patient concerns that you're able to address real time and get real feedback from patients as to whether or not they're not even picking up their medications, but if they're actually taking them, because you have that ability to have a more closely linked conversation with them. So New Jersey has some of the most challenging regulations of all of the states. In 42 states, provider medication dispensing is very permissive. In 46 states, it's fairly permissive. And then there's a handful of states that have significant restrictions on it. New Jersey is the third most restrictive state, next to only Texas and Massachusetts. So just some of the unique things that New Jersey has in its laws that other states have. New Jersey does allow it, but makes it very difficult to do so. It's limited to a 7-day supply once every 30 days, which eliminates the ability to get patients onto a starter dose of a maintenance medication or a full course of some antibiotics, and just really limits what patients are able to do. It has to be in a practice that's 10 plus miles from a nearest pharmacy. There's limitations to the formulary around salves, ointments, and drops. And then there's restrictions around associated services rendered elsewhere. So there's restrictions on if student health centers or publicly subsidized health centers are able to actually do dispensing. In most states, so if you look at New York is probably the fourth most restrictive, but New York has no restrictions on formulary, service type, distance from a pharmacy, or days supply. The only restriction New York has is that the practice can't charge the patient for the medication. But most other states, Delaware, Pennsylvania, pretty much the rest of the country, they go by the if you can dispense, if you can prescribe it, you can dispense it rule. And that's really become one of the best practices, and one of the things that we've seen a lot of enthusiasm for patients on is they're able to easily get their medication without having to go to another pharmacy and wait for 30 minutes to an hour just to get their script filled. And like we said, most states, will have some restrictions on controls. Some states will have additional licensure requirements, but at the end of the day, there may be small additional barriers to getting this implemented. But if you can write for it, you can dispense it prepackaged. With that, we feel very confident in the program that AS Meds runs, but just to keep it focused on dispensing as a whole, it's a very easy solution for practices to implement. It's very safe for patients. All of our medications follow a 102-step CGMP process, so we're more accurate than the pharmacies, and it gives the doctor the ability to really control the patient and control the patient's outcomes. So I'd love to answer any questions that you guys may have.
Okay, thank you, Matt, so much. That's certainly an exciting kind of a option. Now, I know that there'll be a number of questions from the audience, and as the president and our former leadership also both have questions. Let me just start with the major question, which is, what are the obligations of the office in terms of maintaining logs and the supply of these medications? I know with sampling, it used to be such a pain in the ass that a lot of us stopped doing that. So can you tell us a little bit about that, Matt?
Sure. So on the supply side, there's no obligation to maintain a certain minimum amount or anything like that. Obviously, you can't dispense expired medications. You have to buy from a wholesale distributor that's licensed in the state of New Jersey. Some states require an NABP certification for the distributor, which I can go into more details around that. But then there's also requirements around the invoice, which all that falls onto the wholesaler, which would be me in this circumstance. We provide a software for free that allows the dispensing to happen, which does the inventory control, has all the logs for PMP reporting. It does that automatically. Your dispense logs, your end of day reports, all of those things. So the the administrative side of doing this is relatively minor, but there are state requirements that vary some by state, but typically it's daily PMP reporting, which our system takes care of, and then keeping a closure log at the end of the day of everything that was dispensed. And then, obviously keeping an accurate inventory count. So all those things we're able to do fairly simply.
All right, so I have two Donalds on my screen, maybe other people, but the two that I see are on my screen with their hands up. Donald Chervenak, president, gets first bit dibs.
I don't know. The other Donald gets pretty nasty, but first of all, these drugs the doctor's office would pay for in advance.
Yes, that's correct.
So you understand one of the main problems we have with doctors in practice is administrative burden. So now we would be putting up somewhat significant amount of money in advance. The amount of money we're charging, we can charge 10% more than what we cost for the medication. What if the medication isn't used?
So there's a couple of things that our company does in particular around that. We buy most of our medication, 85% of it direct from the manufacturer. So we have 14-month dating, at least at a minimum. Then we don't have order minimums. So there's no case pack where you have to buy 100 bottles. You can literally buy one bottle at a time and replenish as needed. So what we see with our practices is their shrink or expired medication is almost non-existent. I have some statistics I could share, but it can vary by who your supplier is, but AS Meds prides itself on having a zero waste program.
Okay. One of the worst things, I'm sorry if I can add a second part, Dr. Swee, before Dr. Sinai.
Yeah.
Okay. We're in a very litigious state. We're ranked as the best or the second best for socking it to the doctors. If the doctor doesn't have the medication in stock, can that be held against them?
Not at all. So this program is completely supplemental. If the medication's not in stock, it goes back to the status quo. Right now, the doctor has no medication in stock and patient gets their medication at a pharmacy. So that always exists. Patients in most states, or I should say most states have statutes that say patients always have the right to choose. So if the patient says, I understand that you're able to give me my X, Y, and Z, but my uncle runs the pharmacy down the street, the patient has the right to say, send my medication to the pharmacy down the street. So this is a completely supplemental, optional program that exists solely for the benefit of the patient.
Don, Snotty.
Oh boy, I have so many questions, and we fought this years ago with the pharmacies, and they'll come out of the woodwork on this one. They'll investigate and send in people from the Board of Pharmacy to check your records. We've got the problem, as Don Cervenak said, with the 10% rule. It's going to be very hard if you can only charge 10% over cost to do the administration, keep all the records. Almost impossible. And so many questions on what about insurance? If the patient has medication insurance, how does that work? Is this only for people that don't have insurance? Just so many things come to mind. And because of that 7-day rule, we're going to have to change. We're going to have to actually get a new law in New Jersey, which will be fought by the pharmacists. So as the law stands now, it's totally impractical to do this. Thank you.
Currently, there's very, very few practices in New Jersey that are doing this. I'm just going to kind of go backwards through your questions. So if there's one that I missed, please correct me. But for the insurance versus cash pay versus employer pay, our system is able to support all of those. There is an adjudicator built into our software. So you would be able to adjudicate claims through a pharmacy chain organization agreement like any pharmacy would. We have a number of sites that actively do that for commercial pay, for Medicare, for Medicaid. That's definitely something that takes a little bit more of explaining, like you said, so many questions. So happy to dig into the specifics there if you'd like. There have been some recent fights that are very similar to the ones you brought up with the pharmacies coming out of the woodwork. So Montana 2 years ago went from being the most restrictive state to being one of the most permissive states. There was it really centered around patient access. It went through their legislature and Supreme Court, and the final ruling allowed for physicians and mid-levels to follow the "if you can write for it, you can dispense it" rule. So we took a number of sites live in Montana this last year, and as you could imagine, there were still some hurt feelings amongst pharmacists who picked up their phone and pharmacy inspectors that wanted to come in and look at everything. I'm happy to report that all of our sites were inspected, 0 observations, nothing negative. They're allowed to continue business, no disruption. And I know that's still a disruption to the execution of business for the practice, but much like patients in New Jersey with the pharmacy closures that are happening, there was an access issue, and this was able to help resolve it. And I think you may have had another question, but so if you don't mind reminding me what that was.
I had so many coupons, which we can use in pharmacies, can use it here. And we're going to have to change the law. As far as I know, you're going to have to change the law to allow more than 7 days. Otherwise, it doesn't make sense, because the sample size would be too small. They don't make 7-day supply of eye drops.
So as far as the coupons go, I'll answer the easier question first. Our system does allow for the practice to run the coupons for those high cost drugs. Truth be told, we see very little of that. Most of the medications are around that are dispensed are the lower cost generics, both acute care and chronic. So if you think of like the HEDIS drugs for Medicare Advantage, that's really what most practices are doing. We do have some really cool solutions around higher cost medications. Coupons is something that you mentioned earlier that we're able to support. So we can get into nitty gritty on how we do that there, but there is a solution for that. But my understanding of the law for New Jersey is that you're absolutely correct that there would need to be something passed to alleviate the 7-day rule. On oral solids, we can repackage down to any size. So I can put 7 or 14 or 2 or 3 pills in a bottle, and that's no problem. But a lot of the treatments that you would want to see are either dose packed, like birth control or eye drops or, albuterol inhalers, things like that you can't make into a smaller size. So I do agree that there's probably a fight to get this on parity with what other states allow.
Okay. Josh, before you come in, because you're going to get the last word anyway, I'm going to ask Dr. Malhotra had a question on the chat. Who would be able to dispense? Can the MA or the nurse do the dispensing, or does the doctor have to hand over the medication?
So every state's law is slightly different. The most common practice is that the doctor is able to delegate preparatory steps, administrative preparatory steps to MAs and other members of their staff, which would be, it's a prepackaged bottle. So remember, there's no counting. So grabbing the bottle off the shelf, barcode scanning it through the system, having the label print, and possibly doing the adjudication. The final step of preparation, which is, if you think about it, putting the label actually on the bottle and handing it to the patient, that is what 9.5 out of 10 states deem to be the letter of the law on dispensing. And that final step is done by the doctor to make sure they have the ability to counsel the patient. Now, every state's slightly different. Virginia, for example, the preparatory steps are only able to be done by a pharmacy tech. That's the extreme. It's the only state that's like that. But whatever comes down as the state law is dictates who's able to help with exactly what in the dispensing process.
Okay.
And then currently New Jersey doesn't have stipulations on the delegation for the preparatory steps. So
Okay.
just for current state.
Don, you had another question?
Yeah, if you can walk through something with me. Let's take an obstetrics patient. I happen to be an OBGYN.
Mhm.
And 50% roughly of the deliveries in New Jersey are unmedicated.
Mhm.
So you want to give the person prenatal vitamins.
Mhm.
Some of them are $200 a month, some are $80 a month, and some are $5 a month. The patient says, I want Vitafol. I'm just picking one. Now, you understand that the person at our front desks in most of our offices are borderline suicidal because the minimum wage in New Jersey is $15, and a good desk person is only making $2 or $3 more per hour than that person is. Okay, so understanding that person at the front desk trying to make sure everything is pre-certed, I want the cheapest prenatal vitamin I can get. Wouldn't that require significant amounts of time?
No, not really. So the way that the process normally works is the doctor has full control over their formulary. So there may be 200 prenatal vitamins, and I have a 1-year-old, so I should probably know what the number is, but there's quite a few. Yeah, we'll go with a lot. So when you create your formulary, you're not going to stock 400 medications. You're not turning your practice into a pharmacy. You're going to choose, these are the most common medications that I write for. These are the ones that I think are the best for my patients, and stock those. If there's something outside of that or something that may not make sense for you to carry in your office, not an OB example, but you may be a doctor that writes for something like Adderall, and you wouldn't necessarily want to stock that in your practice. The pharmacy is still there. So the one-offs, the things that
wouldn't
aren't,
the Adderall have to be in a locked
it would.
exclusive?
Yeah, it
Okay.
would. We generally don't recommend, we don't sell Adderall, but we don't recommend that
Okay.
as something a doctor would dispense, just as an example of something that you would always want to script out to a pharmacy. So the pharmacy doesn't go away. For the common medications you're carrying, we have formularies on the high end for primary care for senior patients that range up to 200 medications. We have formularies for specialties like ortho that are 6 medications. There's some doctors that carry 2 or 3 for us. It's everything in the middle.
What if the insurance is rescinded once you give the patient the medication? Will the doctor be stuck?
It's a real-time adjudication. So if the patient, it runs just like a pharmacy does. So when you go to do the adjudication, if the patient has lost their coverage, it'll reject. If it's a product that you're not going to get reimbursed for, you'll get a rejection for product service not covered. And then you can have the patient, give the patient the option to pay in cash, or you can script something else out to a pharmacy.
Don't you see the potential areas of hostility with patient front desk interaction with this? What do you mean I can't get this pill? What do you mean? Our offices are very fragile right now.
I completely understand. So we don't generally see any of that interaction, and we actually just did a very large survey across our 3,600 site customer base. Practice managers, front desk staff across the board understood, rated it incredibly positively, understood that what was stocked was what was stocked. Patients don't lose the ability to get any medication, but they understand that, hey, we carry this on site. if you choose to get this here. Most patients will opt into it. If there's something where, you know, you think of some patients that are on multiple medications, you may stock 5 out of the 6 of them. And they may say, well, I don't want to get 5 here and the 6th at a pharmacy, send them all out. That's no different than what the status quo would have been otherwise. You're just able to provide them a better service for what you can stock.
Okay.
Thank you.
Other questions from the audience? I saw Josh had his hand up. Josh, go ahead.
Matt, can you tell us the practices, those 3,600 practices that you work with in other states, or maybe in New Jersey too? Do they tend to be larger practices, smaller practices? Are there any patterns that you see where this is particularly valuable in certain practice areas or other, other categories I'm not thinking of?
Sure. It's everything across the board, Josh. So we have practices that range from one doctor or one mid-level that carry less than 5 medications, all the way up to large practices with, hundreds of locations that stock, that have 20 plus providers at a single site that carry 200 medications. And most of what we're seeing in our customer base is primary care doctors, but we see a lot of urgent care. We see a lot of student health, orthopedics. So there's a pretty big variety. Some specialists, just because of the nature of the medications that they're typically writing for, unfortunately, are not most likely or not like very common users of the program. But we sort of have a one of everything type of customer base.
Okay. Larry Downs, I see your hands up.
Yeah, Matt, can you don't do any scheduled drugs or any of those types of drugs in your program. Is that correct?
So there's some Schedule 4 medications that we'll do, but no C2s, no C3s. And again, the doctor has total control over their formulary. So if you think that something like tramadol is not right for your practice, there's no reason, no one's going to try to force it on you. You never order it. You just stock what you feel is appropriate.
Right. So the pharmacy doesn't go away for things that the physician feels the patient needs, but they're not willing to stock. This is more kind of the physician looks at what they prescribe 80% of the time in terms of their patient mix, and then that's what they would stock if they were to be a dispenser.
Yeah, absolutely. I think one of the most common examples for that is in our urgent care clients. They almost all stock guaifenesin. None of them stock guaifenesin with codeine. They script that out to a pharmacy.
Okay. Dr. Malhotra had another question. What about storage of refrigerated medicines? Can they be kept in regular fridges, or do they need special refrigerators? I'll get to you next, Miriam, by the way. What about liquid pediatrics?
So all of our, for the refrigerated medications, in most states, it can be stored in a regular refrigerator so long as there's a temperature monitor in there. It doesn't have to be a fancy one. Most cases allow it just to go with a thermometer. We do have about 30 pharmacists on staff. So if you have specific questions about I'm bringing in X, Y, or Z, and I have questions on storage for it, we get down to the product specifics on it and see if it's the right med for your practice, both for what the equipment you have is and if you feel like you'd be comfortable stocking it. But most cases, just a regular refrigerator in your med storage area would be sufficient.
Okay.
And then for infant pediatric liquids, I heard that question. So we do stock a pretty robust catalog of medications that are pre-mixed, designed specifically for that market. There will be some, especially for the youngest of infants, that the way that it comes from the manufacturer, we're not able to repackage into a unit of use. And again, unfortunately, those medications would be sent out to a pharmacy. But the again, the vast majority of what's dispensed are going to be, primary care medications for, say teenagers to elderly adults.
Okay. Miriam.
Yeah, hi. I'm sorry, I missed most of the presentation, but what about anti-obesity medications?
Anti-obesity medications, is that what you said?
Uh-huh. Yeah.
Okay. We do provide those. We do stock those. There's some hair on those from a practical standpoint of would you want to carry them? If a patient in your population or a large percentage of patients in your population will have their anti-obesity medications covered, hey, that's great. We can supply them. We can run it through the insurance. We have all the mechanisms to do it. Those are meds that we typically see getting prior auth to death, but there's also medications like Schedule 4 phentermine, which we're able to supply for some practices that are bariatric practices. So it kind of runs the gambit, but you don't see a ton of semaglutides, Ozempics, Mounjaros being dispensed on site just because of simple cost and payer mix issues. So not the most prevalent thing we see. Again, most of the meds are the standard, the HEDIS drugs, acute care medications, non-controlled primary care meds, and some things in the orthopedic and urgent care space.
Okay.
Thank you.
Dr. Henry Dendial has another question in the chat. How are recalls handled? With recalls, who's contacting the patient with recalled batch, etc.?
So AS Meds buys direct from the manufacturer, and we're able to handle recalls exactly like a manufacturer would. So recalls, as you may know, depend on what the FDA states. Some of them are going to be patient level recalls. Some of them are provider level recalls, and most commonly it's a wholesale level recall. So we're fully in compliance with the DSCSA serialization laws. Every single bottle that we sell has a serial number on it. So if a recall should happen, we're able to execute it based off of the FDA's guidance. If it gets down to the patient level, we're able to pull the patient data out of the dispensing software and let you know which patients are affected by the recall. There's going to be different rules around different recalls as to who does the outreach and who does the coordination. So it's very situation dependent, but we definitely provide the service to hold your hand through it in the event that it does happen. I've been with the company for almost a decade, and knock on wood, we've never experienced a patient level recall.
Okay. Other questions? Okay, that brings us to Josh then. We're going to finish up the session with a discussion between myself, well, as the moderator, Josh, and Matt regarding how to go forward in terms of, this is a PSP session after all. Do we want to work on, as Don Snoddy pointed out, the laws that would have to be changed in a major way? Or is it maybe not worth using our influence on this? So since we also have a fight with our pharmacist colleagues at the same time. Josh, why don't you take us through the situation right now, the current regs, and where we might go or not go, please.
Sure, Matt. If you wouldn't mind unsharing your screen, I can then share a copy of the regulations that apply in New Jersey. Thank you. All right, can you all see my my screen now?
Yes.
All right, so the applicable regulations in this case or 13:35-7.5. And if Matt, if you've identified other regulations or statutes that are relevant, please chime in. But these are the ones that I'm aware of that create limitations on dispensing by physicians. So the way my quick read is that this 7.5a, this section essentially lays out all of the good practices that a doctor should adhere to, keeping drugs in an area that's kept in an orderly and sanitary manner, in accordance with standard pharmaceutical practice. You must record in the patient record. Here's some of the information you need to keep when you dispense. Separate containers must be used for each drug that's dispensed. Limitations on pharmaceutical samples. This is actually, I'm guessing, Matt, not really where the problem lies. I would think that the problem arises when you get to probably H, I would think, right? Charging the patient, limitations on charging a patient a fee.
Well, those are for manufacturer samples, so I think that's still not the super relevant part.
So which part would you identify as most concerning?
Let me get my, give me 1 second, please.
Mm-hmm. Yeah, and I think the relevant language actually here H is also, so the first part of H applies to samples, but I think the second part of H, for any drug dispensed which is not packaged as a sample, you can charge a fee to allow for recoupment of a portion of overhead and administrative costs, which shall not exceed acquisition cost plus 10%. And I guess I will say the reason I'm going, performing this exercise is, well, actually, I guess there are two ways that I can think of to go about doing this. The first is to go line by line in the New Jersey reg and identify the problematic aspects, which has the advantage of being a little bit cleaner and a little bit easier to just, strike language rather than craft new language. But it has the disadvantage that it doesn't really create a sort of a comprehensive regulatory scheme that would ensure the regulator, in this case, the Board of Medical Examiners, that there's actually some, a patient protective function that they're performing. The second option, I suppose, is to look at one of the states that you would identify as really conducive to the safe dispensing of medication by physicians, and then to port over that type of regulatory scheme into New Jersey. And the methods for doing that are ones I can go into. But I'm curious to hear your thoughts on which of those approaches you would take.
Well, so I think section I is where you start hitting the meat and potatoes of what we deem problematic. Mm-hmm. And I think a lot of the, and I'm happy to go through what we consider to be like some of the best case states. But I think we can look at the parts of I that would raise eyebrows, because I think there's really two places that you can focus on that would solve for a large amount of what the restrictive nature of New Jersey's laws are.
Well, Matt, this is Dr. Sri again. So let's assume that Pennsylvania has a fairly unrestricted approach, because I think they do.
They do, yes.
Do they, for instance, allow a charge that's greater than 10%?
Yes.
And do they have a limit, or is it just any charge you want?
It's really any charge they want. So you have to remember there's a couple of different They do have a patient choice charge. So remember, there's nothing that says that you're, you write a prescription for a patient and you can force them to pick it up there. So if you want to charge $70 for a $7 drug, the patient has the right to say, no thanks, and go down the street to a grocery store or another pharmacy and get it. On workers' comp, they do have a state reimbursement fee schedule for employer-sponsored programs. It's directly billed to an employer, and there's proving of savings and ROI there. And then for commercial claims, which would be Medicare Advantage, patients who want to use their insurance, all that, it just runs through as an adjudication against what the payer is going to pay. So that's a contractual rate that's set by that payer. It's going to be based on the average wholesale price with a discount, or NADAC, which is another pricing reference. So the ability in most of these cases for the practice to set what the end use cost is are really limited to cash pay, where patients would have a choice, or employer health, where there's going to be a comparative nature against a PBM. So having that 10% rule is unique to New Jersey, but the other 45 states where this is very commonly done, it doesn't really come up as an issue. And in almost all cases, the dispensed medication is less expensive for the patient, the employer, the plan, than the medication that's ran through the PBM.
Okay, good. What else? I knew about 10%. So what else? What's the other major issue? The other major issue is the 7 days, and I assume that in Pennsylvania they use 30 or even more, right?
There's no days of supply restriction in most states.
Yeah.
Both for bullets points 1 and 2 on page 243. So
Right.
There's no limit on the initial dispense, and there's no limit on the refill requirements. So like if you look at number 2, they can only do the medication at a frequency of every 30 days. Most states would allow you to do a 90-day supply. So
it often Medicaid itself often restricts the patients to a 30-day supply.
right.
So
That's the payer's restriction versus the state's restriction.
Right.
So if you're adjudicating to a Medicare or commercial payer, part of being in network with them is you follow the rules, which is the same thing that would happen at a pharmacy anyways. So if it's rejecting for refill too soon at your practice, it's going to reject for the same thing at the pharmacy down the street.
Okay. All right.
Matt, sorry, Dr. Sway, I don't know if you want to,
Go ahead.
Dr. Mundestin's hand is raised.
Did you want to finish up with your piece, Josh, or do you have anything else there?
No, I was actually gonna turn it back over to Matt to see, are there, it sounds like you're saying the most efficient way to go would just be to remove restrictions from the New Jersey regulations rather than port something over from another state.
I agree with that. There's obviously a political aspect to it, which I would not claim to be the expert on. So there are things that may be considered best practices in other states that help help this go across a lot easier. So an example of this is Florida, which is the state that sees the most physician dispensing. The pharmacy board requires a license and an application for a practitioner to be able to do it, and it's like a $25 fee annually, and that kept the pharmacy board happy, and they never challenge it. It's been going on there for 30 plus years, and there's a nice armistice between the two groups, right? So there may be situations where we'd want to look at other states just to make it politically more viable. But for the language, I think if you're able to remove the that bullet points 1 and 2, the 7-day restriction, and then the one fill every 30 days, you get 99.9% of the way there. That 10% markup, we'd love to see that go, but that's really not going to have much of a substantial effect on the practicality of implementing the program because of, one, how commercial insurance works, and then two, if you're in an urgent care setting, this is a very low overhead, very low time commitment program. So on average, a dispense takes 2 minutes, inventory is automatically managed. It's not, it's not like a pharmacy where they, so at NACDS, which is the National Association of Chain Drugstore, estimates that it takes cost of pharmacy about $12 to dispense a script. But remember, you're not paying for the bottle that's included in that, the cap of the cotton, the time it takes to count, the pharmacy tech. Our cost to dispense a script that we've calculated is less than $2. So that $10 markup still, or 10% markup, more than covers, the cost of dispensing a medication.
Okay, I have Miriam and Larry. Go ahead, Miriam, go ahead.
So I'm part of this private practice AMA chat, and one of the physicians raised a concern about some pharmacies requiring that drugs be dispensed by their doctors. Has anyone heard anything about that? Is that something that may have been in response to now some physician dispensing medication? I don't know.
My comment on that, and I'd love to hear everybody else's thoughts on that, but the only case where I've ever heard that happening is with PBMs requiring the use of their own mail order pharmacy versus a patient's right to choose for a retail pharmacy. Most states do have explicit laws that say patient rights to choose is not in response to just medication dispensing by a doctor. It's also patient's right to choose whatever pharmacy they go to, whether that's CVS or Walgreens or their PBM's mail order. So, that's in clear violation and definitely does not have anything to do with physician dispensing. Most of the laws, minus Montana, have not changed significantly in the last, 10, 15 years.
Okay, Larry.
Thank you.
Just a comment on the 10% markup issue. In many ways, with some of the new models of compensation coming out to CMMI, like primary care first, or making care primary, or some of the private payer models that they're moving to, people are going to get paid more on how well they take care of the patient rather than the 10% markup. So I'm just looking in the future, really restrictive physician dispensing regulations may prohibit New Jersey physicians from actually maximizing their opportunities under these new payment programs, because they're beholden to pharmacists and pharmacy access in order for their patients to do well, on their treatment plan. So I don't want to get hung up on the 10% issue. I'm kind of trying to look forward as the payment systems change and you're more measured on how well your patients adhere. I'd like to have that control in our members' hands than in the pharmacy system. So I just think there's something to think about as we go through this, in terms of not looking at what it is today, but looking at what it might be, 3, 4, 5 years from now.
Fine. Any other questions or comments? I don't see anything else in the chat. Let me just get this one out of the way here. Phil Klein's in Florida. So, Phil, are you dispensing down there?
No, I'm still in Jersey
Okay.
till November.
All right, I lost track anyway.
That's
Okay,
okay.
we don't have to go until 8 o'clock. It is now 7:35. It was an excellent discussion. I think if I understand the tenor of the discussion, that people would be interested in MSNJ exploring what we could do to help with the regulations as they currently exist. Is that the sense that you have, Larry, of the room? No.
You're mute.
You,
I think so. I'd like to hear if there are any objections, strong objections to it. Again, we have our legislative priorities. This would be one we would look at to set ourselves up for the future. But if there's anybody who has an objection, now would be the time to let us and the staff and the leadership know about it.
I don't see anybody with their hand up. So
actually, Don Sonati and Donald Chervenak.
hands up. Oh, Don Sonati, yeah.
Okay, so, Larry, I don't know that we would have a real objection to it, other than how much political capital are we going to have to use to get this passed? Who's going to pay for all of that? Are they going to chip in money to help push this? And would this be something that would gain us membership? Are there people out there that would thank us and join the medical society? Because it really comes down to dollars and cents. Most people won't do this, but there are a few that it might benefit. So how much is going to cost? Are they going to contribute? How much of Josh's time is going to be pulled away from the other issues? And will we increase membership if we got this done? Thank you.
Okay. Don Chervenak and then Nancy.
I would defer. Dr. Mueller hasn't spoken yet, so I can go ahead. Go ahead. Okay. Just adding to what Dr. Sonati said, unless you're in a mega office with tons of people, this is a tremendously expanded administrative burden. And I don't see, well, one, the expenditure of getting it fixed. Two, by definition, are we declaring war on the pharmacies in New Jersey? In other words, I don't see this as a 3-day operation of taking over the Ukraine. This is more like a all-out war. So I'm just mirroring what Dr. Sonati said.
Okay, Nancy.
I agree with that. I mean, just as a solo practitioner, this is way beyond anything that I would do because I would have to hire staff. I have enough staff as it is. And number two, I do not think it would bring in more membership. And number three, I think we have better use of our political capital than this, but that's my opinion.
Okay, Josh.
And
Josh, wait.
Oh, sorry.
Phil, yeah.
Yeah, I concur with what Don said and Nancy. I think that this is unless you're in, as Don said, unless you're in a mega group and you had staff that could do this, this is something that I think would be just too much for a solo practitioner or a group of like 2 or 3 docs to handle. Maybe if you're in a primary care group, like with Summit Health, maybe, yeah, it could work, but except for that, I don't think this is a good move.
Not at 10%.
Correct, Don.
Josh, and then I'm going to ask Matt to comment as well. Go ahead, Josh.
Yeah, so the only thing I will add is there are a large number of bills that we don't make our top priorities, but we still, push them gently. We'll craft them, we'll float them with some legislators. We'll push them slowly over time. So I will say that, to make something a high priority bill, that uses up our capital. But in terms of medium and softer pushes, I'm not terribly concerned about a bill like this, a relatively limited change to the Medical Practice Act. I'm not really concerned about that using up much political capital. And the other thing I'll add is, although it may not be terribly relevant to a 1 and 2 doctor practice, there are very few 1 and 2 doctor practices left. And with the consolidation in the market, I think there are fewer in the future than there are now. So just keep that in mind. That
I'll add one thing too. And this is the attraction of this issue for me. Pharmacists have no problem coming after your practice, doing vaccines, doing all kinds of medical work. Why not throw a bill in to kind of level the playing field? So, I mean, we never go on the offensive on quote unquote scope creep. Why not do it? This is an opportunity to do better patient care, give you a little more control, whether you use it or not. At least it keeps some of the pharmacies scope creep at bay, even though Matt kind of judiciously said it's not scope creep. It'll be perceived as scope creep, but I think it could benefit people, and it might be something to throw out there that we're not afraid to say physicians should be able to dispense what they write. Whether you do it or not is up to you. But I think it's got some more legs than you all are giving it credit for.
Yeah, and it's not like the pharmacists, independent pharmacists, or certainly large pharmacy chains. It's not like they're really frequent collaborators of ours. We don't really need them on the vast majority of our issues.
Nancy, you still have your hand up, or did you want to?
I just want to come back. If you're thinking of doing this as a, I don't know, run it up the flagpole, see what we can do to the pharmacists, that's one thing. And if it's going to help membership, that's another thing. But I think that a lot of your most active members within the medical society are of small practices and are of those few. And so if you want to say, well, there's not that many of you left, well, I would look at the exact kinds of people that are active in our medical society, who are part of our medical society, that continue to pay dues, and not just look at it's good for the big guy. So if it'll help membership, and if it's saying, nah, we can do something, which is very petty and juvenile, but I had fun doing that. That's fine with me. So I understand what Larry's saying, and I think it's probably a good idea just based on that. But please don't make light of that there aren't that many 1 and 2 people practices. There are still small practices, and we tend to be the ones who support medicine very vigorously because we are on the front line. So I took offense at that.
Okay. All right.
I apologize for that offense, and you are right that it is the small practices who are here on this call tonight, and I recognize that, and I will continue to fight for you.
People, Naveen, and Nicole.
So I just want to go ahead and give a perspective from a sort of a small practice, but going towards the medium side. I think being able to dispense basic medications would really help, especially in something like pediatrics, where we see a very high volume of patients in a day that may need antibiotics, that may need some basic medications. And for them to go ahead and visit me and then get a prescription and then have to go to sit in the pharmacy for an hour to get a medication, especially during winter season, is a lot of waste of time. And I think if we're able to go ahead and provide that service through our office and hand that medication over to the patient in 5 minutes, hey, then that's an added value that I'm giving for better patient care. I may or may not choose to use it. That's up to me. But I think by being able to provide the service at the point of care is something that's going to benefit the care of the patient. And yeah, if I'm going to get a few extra bucks from this, sure, why not? There's enough burdens out there, and I can choose which burden, academic or which administrative burden to take on. So, and especially if we think that there's not going to be added capital that we have to invest into this, then I would strongly support this.
Okay, Nicole.
Speaking for someone who does primary care, family medicine, I could think of umpteen times when I would love to be able to, like I did in the old days, open a sample cabinet and give the patient a medicine. The asthma inhalers are like a nightmare. You try to prescribe it and then they go and it's not covered, it's not preferred. I go back and forth 4 or 5 times, and we have, with Summit Health, we actually have that bridge where we can look at their formulary and see what's on formulary, and it's still wrong a good amount of the time. So asthma would be huge. The UTIs, that would be helpful. The cellulitis, the antibiotics for the colds and the sinuses, not colds, we don't prescribe it for that, but you know what I mean, for the appropriate, I think it would definitely be helpful. But I think there is an administrative burden, and a lot of us, like Naveen said, we have to decide, is that something we want to take on? I'd recommend 2 things. We could do a survey monkey of members and see if they think it would be something that they would find valuable. The other thing would be if there was, again, HIPAA compliant, or you could just simulate it, but a video that basically shows us the steps, like, okay, it shows the doctor in the room with the patient, I'm going to prescribe this medicine, literally what we see, the steps that are done, so that we can see, is this something that is, workable in our office? Because the current step that I have of, I make the diagnosis, that's the easy part. I literally will talk to the patient while I'm on the computer going, this is going to take me as long, if not longer, than the rest of your appointment, because I am now going to figure out what medicine is approved. I'm sending it. Nope, that one's not on formulary. Nope, this is a tier 6. I don't even know what a tier 6 is. Back and forth, back and forth. I can spend 10, 12 minutes just trying to figure out the medicine.
Easy.
Yeah, so I would like to have that ability. I just need to know how burdensome is it going to be. And if there was a walkthrough, I would appreciate that. So if we could do a survey monkey, figure out how many members would appreciate it. And then the other would be maybe a pilot of, some practices that are willing to do it. And then we can get feedback and see, is it something? But I know we'd have to kind of do the legislative fight to get a lot of it approved. So, we'd have to see how many people would like it. I would love to have it.
I point out that a lot of the stuff that you want to do actually falls in the 7 days, cystitis and UTI and all that kind of stuff. You could probably do antibiotics now. Same thing.
Oh, sorry. Can I just follow up very quickly on that? One other thing on, I totally agree with everything Nicole said. The cost, did they say that we have to buy the medications up front and stock them? Or is this something that they would supply for us, and then whatever we use, we use?
Most states have laws against meds on consignment. So if you guys wanted, AS Meds would be happy to do that. It would need to be stated in the law that we could do a consignment program for medications.
It would be kind of like, the Vaccines for Children program, where you get the vaccines, you administer them, and whatever doesn't work, you send it back to the state. So, I mean, that's something that I would want to go ahead and push for.
Okay. Matt, do you have any comment about showing a video of how it works?
It's funny. We actually built one for one of our clients that does employer health. I would need to get their permission to use it because we branded it for them, but they do run primary care sites in New Jersey for employers where they would like to have this program. So I think that is something where I could get them involved, and not promising, but could be additional membership there. One of the other things that came up was concerns around small practices. We do a very large number of small practices. We actually have a partnership with the Direct Primary Care Coalition, which is exclusively 1 or 2 doctor practices. So we'd be happy to grab one of our clients from another state that looks more like, the very well represented small practices here, and let them tell about how they do it at their office and how it works for them.
Okay, so both 2 things, Matt. You have 2 homework assignments. See if you can get us a video, and then see if you can get us someone to describe what they do back at home. Any other questions or comments? It is now 10 to 8, so we've used up most of our time. Appreciate this very lively discussion. I certainly think we heard things on both sides. Sounds like people are willing to go forward as long as we don't kill ourselves on cap, no stamping ourselves with too much cost. But on the other hand, if we could get some of these things done, and Naveen has asked for additional, maybe on consignment even, that would be nice too. So we have to find a state that has that, so we can adopt that maybe as well, or bring it back in. All right. Is there other discussions? If not, I'm going to ask for a call for adjournment.
The expression should be, we shouldn't